Distinguished ladies and gentlemen, I am delighted to welcome you to this Community Connect session. The title of this session is Strengthening TB Services Through COVID-19 Response, Lessons Learned from Nigerian Program. Yes, you are in the right place. This session is organized by APIN Public Health Initiative, Nigeria. My name is Paul Okoye, and I am the CDC Nigeria Laboratory Branch Chief. I will be moderating this session, which promises to be a very stimulating one. May I also introduce my co-moderator, Dr. Plank Joanwale, who is the HIV Treatment and TB Services Program Lead for APIN Public Health Initiative in Nigeria. In this session, we will be looking at the innovative strategies adopted by the APIN program and teams in Nigeria to mitigate the impact of COVID-19 pandemic on access to TB services. We shall see how the team, through a project funded by CDC, integrated the screening and bi-directional testing of clients for both COVID-19 and tuberculosis. The team will also walk us through the key lessons learned from the implementation approach. We have a recorded joint presentation by Dr. Obong Okon, who is a public health specialist, epidemiologist, and biostatistician with the Strategic Information Department of APIN Public Health Initiative in Nigeria. We'll also be hearing from pharmacist Kaneng Paul, a technical advisor in the pharmacy department of APIN Public Health Initiative in Nigeria. You will also be hearing from Dr. Enenche Ediga, who is a senior technical officer in the clinical department of APIN Public Health Initiative in Nigeria. May I inform you that after the presentation, we shall have ample time to answer your questions, get your feedback, and have you share your thoughts on this innovative program intervention. Note that at any time during the presentation, you may post your questions using the Q&A function, and we'll have them answered at the end of the presentation. Ladies and gentlemen, at this juncture, may I now invite Drs. Obong, Kaneng, and Enenche to make their presentation. Thank you.
Hi, everyone. Good day. I'm Dr. Obong Okon. I work with APIN, the Strategic Information and Research Department of APIN Public Health Initiative. With me on the call is Dr. Enenche Ediga, and from Kaneng Paul. Dr. Enenche Ediga is the central coordinator for the TB COVID Innovation Project, while Farm Kaneng is the pharmacy advisor for the project. We are here to present the findings for our project titled Strengthening TB Services Through COVID-19 Response, Lessons Learned from Nigerian. We would like to welcome you to this section, and we want you to feel free, send in your questions. We're glad to answer them as much as we can. Dr. Enenche will be leading us in the aspect of project description, while Farm Kaneng will take us through the aspect of the background of the project. I also will move us through the results and finally the conclusion and recommendation. You are welcome to this section. Please, Farm Kaneng, can you actually take over? Yeah, thank you.
Okay, thank you, Dr. Obong. And You're all welcome to our presentation. So at the peak of COVID-19 pandemic, Nigeria instituted several interventions as measures to prevent the spread of the disease. These interventions included physical distancing, total lockdown, and movement restrictions. Also, there was diversion of funds to the COVID-19 response. These activities had negative effects on access to healthcare services, which was evident in people's poor health-seeking behaviors due to fear of contracting the disease. And as such, TB case finding and treatment were adversely affected as well as other health service delivery, such as ART. To reverse the possible impact of COVID-19 pandemic on TB case finding and treatment, APIN integrated COVID-19 into TB services by operationalizing bi-directional screening and testing for patients who are presumptive for either TB or COVID or both, and also leveraging existing TB Gene-Xpert laboratory network for COVID-19 testing. The project focused on improving access to TB and COVID-19 services through integrated screening, testing, and linkage to care services during the COVID-19 pandemic. And it also implemented infection prevention and control measures in order to decrease the transmission of COVID-19 and TB among clients visiting health facilities through differentiated service delivery models. The project was implemented as follows.
What we tried to do then was to ensure that all patients that were seeking health services were screened for TB and COVID-19 at the OPD, the ART clinic, the DOT unit, ANC, and also the COVID-19 sample collection site. We did this by using the bi-directional screening form that we adapted from the standard TB COVID-19 screening checklist developed from the national COVID-19 and TB screening algorithms. So in doing this, we ensure that all presumptive patients for either TB, COVID-19, or both were referred to a central point, which is the DOT clinic, for sputum sample collection, and referred those who are unable to produce sputum to other method for diagnosing TB. And after all of this, we escorted these patients to COVID-19 sample collection point where their samples were collected and moved to the Gene-Xpert lab for testing for both TB and COVID-19. And those of them that were identified to have TB were linked to TB treatment at the DOT clinics, while those that were positive for COVID-19 were referred to the disease surveillance and notification officers for linkage to COVID care. We actually implemented this project using some tools that we adapted from the national program, because we decided we did not produce new tools. Tools like the TB COVID-19 screening form, the National Presumptive TB Register, the National Presumptive TB Register, and the Treatment Register, and SARS-CoV Lab Testing Register. After implemented this, we have the following results.
We screened 78,852 patients across different service points, such as the DOTS, the GOPD, the ART clinic, and the sample collection points. Out of the total screened patients, we recorded 14,988 presumptive patients. That is, patients with at least one symptom of COVID or TB. The presumptive yield recorded was 19.0%. The presumptive patients were evaluated for TB and COVID. Some were evaluated for TB only, while others were evaluated for COVID only. 11,142 patients were evaluated for TB and COVID-19. 3,901 patients were evaluated for TB only, while 627 patients were evaluated for COVID-19 only. A total of 14,860 patients received different forms of TB and COVID evaluation. Among patients evaluated for TB and COVID, 1,140, that is 7.7% of the patients had TB. 894, that is 6.0% positivity yield of this patient had COVID. Among patients evaluated for TB only, we had 446, that is 3.0%, had TB, while 203, that is 1.4%, had COVID. 88 of these patients were positive for both TB and COVID. When you look at our slides critically, you will discover that the total positivity yield among the presumptive patients by evaluation categories shows that 1,097 of the patients were positive for COVID-19, while 1,586, that is 10.7% of the patients, were positive for TB. Out of the positive patients, all the positive patients, 1,073 of them TB positive patients were linked to care, giving us a linkage rate of 95.6%. It's critical to note that if bi-directional screening and testing were not implemented, 247 COVID-19 patients would have been missed because they were presumptive for TB only. By default, they could have been evaluated for TB, only TB services. We also noted that 211 positive TB patients could have also been missed among COVID-19 presumptive patients because by default, they could have gone for only COVID evaluation. During this project implementation, we learned some lessons.
We learned that the integration of COVID-19 and TB testing, if well coordinated through the DOT clinic, it's fixable, it's effective, and efficient. We also learned that the expansion of symptom screening, that is, to other service delivery points like the OPD, ANC, the ward, the TB clinic, has been able to help us to reduce missed opportunities and increase TB and COVID-19 case finding. The use of multi-pathogen testing for TB and SARS-CoV on the Gene-Xpert equipment by trained laboratory scientists created opportunities for increased access to TB and COVID-19 testing, and also help us to optimize utilization of the Gene-Xpert facility in country. APIN also leveraged on COVID-19 funding to optimize Gene-Xpert utilization, increase TB case finding, and strengthen referral and linkage system for TB and COVID-19 across implementing facility in the selected states where we implemented.
Bidirectional screening and testing helped to improve access to TB and COVID-19 evaluation across the implementing sites. It also strengthened TB and COVID case finding in the states where we implemented. We therefore recommend bidirectional screening and testing across health facilities in Nigeria and countries with high TB burden. However, more research is needed on the economic evaluation of this approach among countries with low TB burden. Thank you so much. Thank you very much for your time, and we hope to receive your questions, your comments, and your concern, and hope to also answer them accordingly. Thank you so much.
Okay. Thank you so much, Drs. Ubong, Kaneng, and Enenche, for your great presentation and for the brilliant work you have done integrating COVID-19 and TB screening and testing in Nigeria. My name is Dr. Plan Juanle, and I'll be moderating this question and answer session. I'm yet to see any questions on the chat, except for a question on whether the slides will be made available after this presentation. So I want to ask if there are any questions, they should be posted on the chat, and we shall make efforts to respond to them. Thank you.
While we wait for the audience to post a question, may I ask Drs. Ubong and Encha and Kaneng if they could share with us what were the major challenges they experienced while implementing this innovative approach?
Kaneng, Enenche?
Okay, so let me mention one of the key challenge we had was integrating COVID-19 services into health facilities. You know, at the peak of the pandemic, there was this fear of people had this fear of contracting the disease. So some health facilities, in fact, we had a decline, an outright decline from a facility because many patients now refuse to access healthcare services from that facility because they had tagged it as a COVID-19 facility. So those are some of the teething issues we had at the beginning. That fear of going to the facility was there because many facilities were being tagged as facilities implementing this research were being tagged as COVID-19 facilities, and therefore people did not want to access health services at the facility. That's one key challenge we had starting. I don't know, my co-presenters could also present other challenges as well.
Okay, in addition to the challenges Kanem has mentioned, we also experienced refusal by patients who actually refused to get COVID evaluation. You know, as we expanded to other service points, patients that came into the facility for other health conditions were screened for both TB and COVID. Since we had an expanded symptom check,
Any patient with at least one symptom included in the evaluation received either TB or COVID evaluation. So we had situation where patients who eventually had one symptom refused to take the COVID test because actually they believe that COVID is not there's no COVID. We these challenges were prominent because at that period COVID cases in the states where we're implementing are already winding down. So some measures has already been some restrictions have already been relaxed. So people are not actually believing that COVID. So these are the challenges we had. We also had challenges where people that came in for the COVID evaluation still they don't have TB, so they don't need to be tested for TB. They just want to. So these are the issues we had in area during implementation. Just as also said, we had issues among the facility staff who were implementing. They actually do not believe that we could implement such in the facility. Apart from facility management, also we had issue with facility staff also. But as we got them integrated into the project, as we kept having a review meeting with them, everything started becoming interesting. Seeing other facilities who are doing well, they felt the need to, work on the project. End of the project, we were able to overcome some of these challenges.
Excellent. Were they, do we have questions now, Dr. Plank?
We have a question. What's the plan to scale up the intervention?
Okay. Currently, as I'm talking to you right now, bi-directional screening and testing is still ongoing at the facilities where we have implemented. And also, we actually also have integrated bi-directional testing and screen and testing in other facilities within the states. Plan are on the way to scale up this approach in other states in Nigeria, and I believe that the National TB program and other partners are working towards this to ensure it's done. But within the states where we're implementing, scale up, scale up is ongoing, and I believe that sooner or later, there will be scale up across all the states in Nigeria, all the facilities in Nigeria. I think I leave the space for a room for Dr. Nature if he has anything to say on this.
Just to buttress what Uban had said, currently COVID-19 integration into TB services has already come to stay in most of our facility as we are implementing now. As patients come in for services, as you screen them for TB, you also screen them for COVID. During the implementation, we actually used the PCR testing platform, but now with the RDT available, we're ensuring that both tests for TB and COVID are also done as the patient are presumptive. So for integration, that's already ongoing, and we are hoping to continue and strengthen the system to ensure that we get more cases of TB among patients who are presumptive for COVID. Thank you.
Thank you for that response. We have another question. How were you able to manage sample referral requirements for COVID-19 and TB samples? Was this a challenge? Dr. Nenche, I think you can respond to this.
Yeah, so except for local government where we had issues with security, where we needed to reroute the sample, most of the sites that we implemented were activated testing sites. So sample management were not much of a challenge as samples were collected they were seamlessly moved to the lab for testing, except in some instances where we have stock out of cartridges where we have to now ship the samples to open lab where they are tested and then we get the result back. Other than that, we really didn't have much issues with sample management. Thank you, and over.
Thanks for that response. I don't know if Karen has anything to add.
Well, nothing to add actually. I think NHA had addressed the question on the sample, but we already had a system of sample logging where we didn't have the Gene-Xpert machine. So samples were well managed and then moved, of course, by designated personnel to the lab. So all that was already addressed before implementation. So we had a seamless sample logging system that was in place. So we didn't have any challenge with moving samples. Thank you.
Okay, that's fine. We don't have any question, Paul.
That's okay. Just also wondering, how receptive was the TB, or how did you coordinate with the TB program to ensure the integrated service delivery of COVID and TB, knowing how sensitive this can be, given that each these programs would want to make sure that there are no negative impact on case finding. How did the engagement happen?
Okay, so before we started implementation, we have several engagement with right from the national TB program down to the state before we started implementing. And again, at this period, like we said, service delivery for TB and case finding were on the downward trend. And they actually realized that if we integrate COVID services into TB, trying to find TB cases was a welcome development. So we tried to engage with them from the national TB program down to the state, where we also had start-up meeting with the facilities, and we got their buy-in to ensure that we start this implementation. And we also had a period where we had to have a joint facility visit to the site where we implemented for them to also see what we're doing. And so we had no issue at the end of the day. Thank you, Anova.
So apparently you have the support and the facilitation of the national TB program to roll this out.
Yes, yes. During the engagement, we sought for their buy-in, and we got that. And then during the implementation, we giving them feedback, and they also came to the site to see what we were doing. Thank you.
Excellent. Were there some need for standardization, especially given that you have to do integrated screening? Were there some need to standardize the screening tool?
TFC, Tensional Compound. This is post one. The time is now 18:30 and the embassy is officially closed. All personnel remaining in the building are reminded.
There's some interference. What?
So did you get the question? I was asking if
I think there was an interference, Paul. So.
Okay, sorry about that. I was wondering how you manage the screening tool. Did you have to standardize the screening tool to be able to apply it for COVID and TB screening, knowing that the screening checklist is mostly um, optimized for TB screening?
Yeah, so during my the project description, I actually said we try as much as we can based on the algorithm and the guideline of COVID case definitions, the symptoms and all of that. So we standardize the tool by bringing in the COVID question part of the tool and then combine them together where we have those questions for TB and the one for COVID. So we actually have a standardized tool for this screening, which we deploy to the site, and that's what we use in screening to get the presumptive cases for linking for bi-directional testing. Over.
So for countries participating in the Union Conference that may want to replicate this initiative in their various programs, how would you advise them to start? And
Okay,
I think
just
it
like
would be good to get contributions from all of the panelists.
So maybe Kanen would want to respond.
Okay, so also in addition as to what NHA had said regarding standardization, we didn't create entirely a new tool for screening. What we did was to adapt existing tool but merge the screening tool for TB with the screening tool for COVID-19. They were already existing in country. So we merge. Of course, you know that the symptoms for COVID and COVID-19 and TB has similar symptoms of cough and so many other similar symptoms. So it was easy to really just merge and utilize the tool. Of course, there was a test run to see how effective that would be, but of course, further capacity building for healthcare workers was done for efficiency in screening. Of course, you know that if you don't apply the tool well, you will likely not get any presumptive at all. So there was need for capacity building for the healthcare worker using the tool so that we have efficiency in screening and also identifying presumptive cases, because that was critical for the project implementation. So for countries who would want to adopt or integrate this kind of services, first and foremost, would advise that you identify or rather use tools already existing tools like the screening tools. You can adapt them and then apply. What we did was to drop this tool in all service delivery from OPD down to the ART units and also the dot units and even the sample collection units for COVID-19. Of course, those were peculiar to those times. That was peculiar to those times. We had such kind of disintegration of services. So it was necessary that we identify such service delivery points and then drop those tools. So first and foremost, simplify the tool for screening, okay, and then identify a coordinating point for linkage. So for us, the TB dot unit was ideal. So that served as the coordinating point. So all presumptive were sent there for further referral to other service delivery points, like for HIV testing for those who will require that, and then for the sample collection for COVID-19 screening for those who, for the bi-directional testing. So identify a coordinating point where You can easily coordinate your referrals to other service delivery for further services. Then linkages, it's good to, what we did was to coordinate between three main service delivery points. We had or service or disease points, let me say. We had the ART unit, we had the COVID-19 response unit, and we also had the TB unit. So you must have a coordination, a good coordination of those three, at least those three units, and also get the buy-in of the facility where you will implement such. Of course, now COVID, as it is usually said, has come to stay. So most of those stigma associated with it is not existing anymore. But when you are able to coordinate those different partners or stakeholders, you would be able to have a seamless implementation of the project. So those are some of the critical things like we have identified in the in our lessons learned that you could apply for a robust implementation of the these innovations in your country. Thank you from my
So
end.
yeah. In addition to what all that has been said, I want to say that one of the another important thing we should look into is proper stakeholder integration. Proper stakeholder integration. At the early stage of the project, we had a lot of issues at state level, at the facility level. You know, they do not see the reasons why we should bring in integrate COVID into TB screening or TB management. But as we move on move on with the project, you know, they started seeing the benefits of having this service integrated, and all of them started enjoying it. So before you do this, you need to, do a proper stakeholder integration. You know, let them know the benefits of having these services integrated. Another important thing, just like she has already mentioned, is issue of capacity building. I could remember that it took a while, even after we have done our trainings, because we are doing regular review meetings. The clinicians were really involved. Every healthcare workers involved at different levels got involved into what we are doing. And at the end of the day, it was just like facilities that could do that were actually not doing COVID testing before started doing COVID testing. COVID case finding in the state were improved. TB case finding in the state were improved. So right from baseline assessment, assessing the facilities capacity, doing the relevant training, providing relevant tools. There's other thing again we also did. We try to adapt the already existing tools at the facility. At a point wanted to have more tools, but we discovered that the more tools you have, the more burden you are creating among the healthcare workers because they have other things to do. So we find a way to adapt to the existing tools, and that worked very fine. So whenever you want to mention, you want to do extra thing, give them extra task, they see it as more work. But by the time you integrate what you have in the existing structure, they actually appreciate it over time. So you build a capacity, you see a way of integrating this into the existing tools. You try to let them understand the flow, the workflow, the processes, and by the time they get this, they understand this, you have a seamless integration, and most importantly also, as you try to work on the project, you also have a time to review what you're doing. I think at this point they'll start appreciating whatever you're doing.
Okay, that's great. Uh, Paul, I think in the absence of any other question, let me just hand over to you. Thank you very much, the presenters, for doing justice to the questions.
Thank you so much.